Okay, let's come back to our class. For the next 20 minutes or 30 minutes, I'm going to talk about the trauma of the lower limb. As you know, the lower limb is quite a big region, and due to the time limitation, I would like to focus on these four most important sections of the trauma. The first topic is hip dislocations. Hip dislocations usually result from significant trauma, such as massive vehicle accidents. The posterior hip dislocations are the most common type of hip dislocation. When it happens, the patient usually sits in a car with the hip flexed, a little inner rotation and adduction like this. And then the car comes to a sudden stop, and the knee will hit the seat of the frontal seat. And the mechanical force will transmit it to the hip and dislocated the hip posteriorly. This is the thing of the hip dislocation like this. The patient was fixed in this way. The leg is a little bit in a rotation and adduction. The leg cannot be placed straightly. There are significant pain here in the hip. And if you image the dislocated hip, you will have something like this. The femoral head dislocated posteriorly as relative to the acetabulum. Another pretty rare type of hip dislocations is anterior dislocation, and this exactly happens under opposing mechanism. After the anterior dislocation, you will find the femoral head goes anterior to the acetabulum here. This is not so common. Actually, in my career, I only met one case of anterior dislocation of the hip. Emergency is necessary for reducing the risk of deep vein thrombosis and vascular necrosis. For all patients with hip dislocations, you should keep in mind that these are emergent cases. You should do something in the midnight. And the closed reduction typically performed under anesthesia, and you need, as the muscle around the hip and in the spine are much stronger than your muscles in the forearm or upper arm. And for these reasons, you need a team. You cannot make it by all yourself. Alice maneuver is the most common used approach to reduce the dislocated hip. And usually we will directly let the patient lie down on the floor. And in this way, we can best use our muscles to track the leg or thigh. And your assistant should press the pelvis down and fix the pelvis. And you gently, actually, you can use your elbow to grab the thigh or knee joint and gently track the leg. If you use your hand, perhaps you cannot fully use your muscle power. Here is the detailed maneuver. First, the patient lies down and your assistant presses the pelvis, fix it in the floor, and you use your hand gently flex the hip to 90 degrees and do traction progressively and gently, and last it for a couple of minutes. After the muscles of the thigh relaxed, then you can do a little bit of adduction and inner rotation. If the reduction is successful, you will feel some click in the hip joint, and immediately the leg can be placed down like this. After reduction, you will need to repeat anterior and posterior pelvis film. And the patient should not do hip flexion more than 6 degrees for a couple of days. And the patient probably can start early mobilization under the aid of the physical therapists or nurses. As a physician, you should pay attention to some potential complications of hip dislocations. For example, you should follow the risk of avascular necrosis of the femoral head. After 3 or 5 months, usually I will let the patient have an MR scan of the hip joints to identify early sign of avascular necrosis, if any. Okay, the next topic is hip neck fractures, which is really important to all orthopedic surgeons. This hip neck fracture is one of the most common fractures in the elderly. I would like to talk about these common fractures of the elderly again. There are 3 types of fractures. One we have talked about is collis fracture, another is spine compression fracture, and here is the hip neck fractures, which are very common. And typically we have more female patients than male patients, as osteoporosis is more common in old ladies than old men. And this hip neck fracture usually resolves from only a very simple fall to the floor, and typically it happens in the house. And we will mention later this hip neck fracture is intercapsular fractures. These make sense. Let's simply review the anatomy of the hip joint. This is the femoral head here. This is the neck and the greater trochanter and this lesser trochanter. And the blood supply of the femoral head is mainly from this medial femoral circumflex artery. So if the fracture happens in this side, this blood supply will potentially be destroyed, resulting in a vascular necrosis of the femoral head. And we have talked about the hip joint capsule. The capsule ends roughly here. So any fractures happen at this side are intercapsular fractures, which means they will have pretty bad blood supply for this femoral head. While if the fractures happen this side, then it's extracapsular fracture, which means there are substantial blood supply. You don't have to worry about the avascular necrosis of the femoral head. There are some specific names here. If fracture happens here, we call it subcapital fracture or intercapsular fracture, and this is for the intertrochanteric fracture, and this is for subtrochanteric fractures. Gardner classification is the most common used approach to classify the femoral neck fractures. As I have shown here, there are 4 grades of the Gardner classification. The type 1 is Vargas impacted fracture, here, impacted here, and the fractures are not displaced. And for second type, for Gardner type 2 fracture, you will see non-displayed but complete fracture of the femoral head, roughly here. Type 3 is complete and partially displaced fracture of the femoral neck here, and type 4 is completely dislocated, fully displaced fracture of the femoral head. For garden fracture type 1 and 2, we usually say it's stable fracture. Perhaps we can use open reduction. Now we don't need reduction actually. We can use internal fixation to fix the fractured bone. While for garden type 3 and 4, we say perhaps we need other approaches. According to the function of the femoral head, we can divide the fractures into stable and unstable fractures. As I've talked, these two are stable and these two are unstable. Non-operative approach are barely used to treat the femoral neck fracture, and the way we use are pretty limited. We only can use some kind of skin traction, which is not so functional, and surgery or operative intervention are the most common intervention we use. For example, we can use open reduction and internal fixation, such as using cannulated screws or dynamic hip screw. For older people, particularly for those older than 65 years, then we can use hemiarthroplasty, and sometimes in some cases we use total hip replacement. That means we do not try to heal the fractured bone. We simply replace the hip joint for early rehabilitation. Now here are the images of different instrumentation of the femoral neck fracture. In this case, we use 3 cannulated screws to fix the fracture. And this is so-called dynamic hip screw used to fix the hip neck. This is hemiarthroplasty. This is total hip replacement. Okay, the next one is intertrochanteric hip fractures. And these are astrocapsular femoral fractures. And the area of this intertrochanteric hip is here. It's to the inferior bottom of the lesser trochanter here. Fracture happened in this area. We call it intertrochanteric hip fracture. And as I mentioned here, these are astrocapsular fractures. They have pretty well blood supply. So non-union perhaps or delayed union is not an issue to worry about. These are some cases of different types of fractures. These are not displaced. This lesser trochanter is displayed substantially, and the angle of the femoral neck and shaft reduced to some degree, and these are communicated fractures. And typically we use surgery to reduce the displaced fractures, and fix using internal instrumentations like dynamic hip screw and dynamic compression plate or PFM, as I showed here. This is dynamic hip screw fractures here, almost healed. And this is PFM, using two nails, two screws to the femoral neck and hand, and this is an intramedullary nail down to the middle femoral hand, the shaft. Excuse me. Another topic is femoral shaft fractures, which is usually resulted from pretty massive energy or high energy injury. And we can use intramedullary nails like this, or we can use open reduction and internal fixation with plate and screws. The plate and screws are most common use that we approach in our department to cure the femoral shaft fractures. For the clinical evaluation or radiology examination, I think that is really simple. Obviously, pretty obvious that the patient got a femoral shaft fracture, so almost everyone knows how. The distal femoral fractures also resulted from high energy, and the patient will usually have multiple trauma in the chest, in the abdomen, or in the other limbs. The distal femoral fractures will potentially have high incidence of the post-traumatic arthritis if the knee was substantially disrupted or involved. For example, here is the diagram. We call this fracture line here. We call this supracondylar fracture, and if there's fracture here, then it's condylar fracture. It's a simple single condylar fracture, and this is called bicondylar fracture, as both condylars were involved. And this is a joint fracture. The fracture line involves the joint surface, articular surface, so you should pay more attention to recover this as surface of the joint or the knee joint. For clinical evaluations, typically we just use radiography and CT. This is X-ray. You will see the combinated fractures about the supracondylar. After CT scanning, you will see the sagittal reconstructed image. You will find that there is comminuted fractures. The fracture involves the surface of the articulation of the knee. Here is another 3D reconstruction image. You will find the complicated fracture of the distal femur. Treatment, usually the patient will undergo surgery for early exercise and mobilization, and this is a compressed plated screw system. Here is another dynamic screw system. Here, dynamic condylar screw. Okay, the next topic is another small fracture called patella fractures. If you ask the patient typically will have sometimes fall on the knee, and also sometimes in massive vehicle accidents, the patient without multiple fractures will involve the patella. Patient probably will fall down on the knee, so the physical force directly act on the patella resulting in fractures. Clinical evaluation includes the pain, local pain, significant swelling, and local contusions, and you will find some lacerations around the knee or other places, even the head. And gently you may touch some defect in front of the patella, because it's palpable defect as the fractures are displaced and there is a gap between fractured ends. And the patient usually cannot or is not able to straight leg raise, just fixed or immobilized in kind of protecting position, won't let you touch so much. Here are some different patterns of the patellar fractures. For example, transverse fracture and vertical fracture, comminuted fracture, or these osteochondral fractures. Here's a case you see the patellar blade is broke into multiple pieces, and we can fix the patellar fractures with K-wires and steel lines, steel wires also. There are a lot of different techniques to fix the fractured patellar. For example, in this case, we use steel line to just simply bind this patellar. These two are K-wires, and these we use A-shaped steel wires to bind the patellar. Occasionally, we also use screws to fix the fractured, break the patella, and combine the screws with steel wires or K-wires. Let's go down to the tibia plateau fractures, and these is usually resulted from the massive vehicle accidents or fall from significant height or support injuries. We should carefully examine the soft tissues to make sure the neurologic integrity. For example, the peroneal nerve is fine, and vascular examination is very important, especially with medial plateau injuries. And as a physician, you need to be aware of compartment syndrome. As I've mentioned, there are two anatomy locations which are prone to have the compartment syndrome, which is a serious complication of fracture. One is the forearm, another is here, tibia plateau fracture, is a lower leg. And also, you need to check the knee ligamentous instability. When the tibia plateau fractured, they are, according to a report, that potentially will have 20 to 30% patients with the ligamentous injury. As usual, we will classify the tibia plateau fractures like this: type 1, 2, 3, and the complicated fracture of the tibia plateau 5, 4, 6. And for these upper three types, it's called stable. We need a simple reduction and perhaps plaster immobilization. For these three types, we typically use surgery. And the plate and screws are most commonly used to fix the tibia plateau fractures like this. The medial plateau compressed down, displaced, and we use a plate and screw system. Here's another case called the lateral plateau fracture, and we fix this also with screw and plate system. While the tibial shaft fractures can occur in lower energy torsion type of injury, and open fractures of tibial shaft are more common than in any other long bones. And the skin, the bone is right behind or below the skin. So it's really easy to have open fractures. Here's a case as you see both the tibial shaft and the fibular shaft fractures. Here are open fracture cases. You see the soft tissue around the tibia got seriously injured, and the fractures are widely open. In this case, it's even more serious. Muscles are almost destroyed, completely destroyed. Typically, we will require surgery to repair the injured bones and muscles or skin. And as always, the plate and screw systems are the most commonly used instrumentation. And in this case, we use the intramedullary nail system to fix the tibia shaft fracture. Okay. I want you guys to pay a little more attention to a special fractures of tibia shaft fracture. It's called pilum fractures. Pilum fractures means the fractures involve the distal tibial metaphysis and into the ankle joint. And in these cases, the soft tissue management is very important. And usually we say excellent results are pretty rare. Just fair or so-so will be great. Multiple potential complications may occur after in the case of pilum fractures, include marred union or non